In this hour, I'm gonna go over the overview of MRSS. I want to again thank Dr. Manderscheid for a wonderful presentation that is very grounding in this whole idea of it takes a community to, help all of the youth and families. We need a community response. All right, Laura, I think you're controlling slides, I guess. Thank you. So, to follow up on Dr. Manderscheid's, keynote, the youth and family safety is a community responsibility. So safely maintaining youth in the least restrictive home and community-based setting requires community ownership, responsibility, responsiveness, and participation. I've worked in the field for many, many, many years, and the one thing that I've realized over the years is that no one single child serving system can manage the complex challenges of youth with multiple behavioral health needs and their families by themselves. It really does take a community response. One of the things that I really think is quite helpful is when we pull together a child family team or a wraparound team to plan for ongoing care for those youth and families and their needs. Community partners need to work together to implement a sustainable continuum of services for its children, youth, and families. I think the other piece of this is that, Medicaid in and of itself is necessary but not sufficient for a majority of our mental health services, behavioral health services. So as a community, how do we come together and care for our own? Next slide, please. So there's a lot of very good information that's being put out, and it's all very recent, whether it's 2020, 2021, either from SAMHSA or the new roadmap to ideal behavioral health crisis system put out most recently. But their messages are all the same. Basically, crisis services should be available to anyone, anywhere, anytime. We should be able to increase access and timeliness of response for the purpose of decreasing use of emergency departments, law enforcement, or the juvenile justice system, and should be an essential community service, just like police, fire, and EMS. So the fact that it isn't currently is really unacceptable. So these things should be an expectation in each of our communities. Next slide. So let's talk about mobile response stabilization for the rest of my slides. I will be calling it MRSS. And this is really kind of a slide that talks about this next evolution of crisis response for youth. So, when I started my work, we had crisis hotlines, and those crisis hotlines were mostly for adults. About in the 1990s, then all of a sudden there were some crisis hotlines that had adolescent providers that were hired to help on certain shifts, answer calls. Fast forward into 2000, 2010, we started to have mobile crisis units available for adults as well as children. Many of the mobile crisis units did a wonderful job, but they were geared toward a more compressed time frame of 24 to 48 hours. Let's go in, let's stabilize. Let's do our quick assessment about what this youth needs at this point, and let's link them. So it was all very quick, very immediate, and it was really geared to immediate stabilization and then linkage and a little bit of monitoring. Because some of these units, as I said earlier, we haven't done a globally effective job of making these services available in all of our communities. So there's variable rates of mobile response to calls in terms of how we staff these programs really limits how many persons can go out mobilely, right? The other piece here is that the mobile crisis teams traditionally, and the hotlines traditionally would always try to stabilize something via a phone call, and then if not possible, then and if they had staff, that they would go out. So they had limited time frames. They had limited time for linkage, planning, and ongoing monitoring. Fast forward to Mobile Response Stabilization Service, and to remedy some of these issues. This service, I believe around 2005, 2006, began being piloted, I think in New Jersey. Jeff would help me if I'm wrong. And have since been piloted in Connecticut, and certainly were developed in wraparound Milwaukee years ago. But these services are different in that the expectation for every call is a mobile response, and that's quite different. And that mobile response needs to happen within 60 minutes. So these are the expectations of MRSS. In addition, there's an expanded time frame, and that's significant because then you have up to 4 to 6 weeks to go in and do further stabilization, further skill building with the family, to make sure that things are a little bit more stable and secure and linked, if you will. So there's more time to address skills needed to reduce the frequency and acuity of future crises. Another key aspect of MRSS is that the youth and family define the crisis. It's no longer defined by the professional receiving the call. It's defined by the youth and family. Next slide, please. So this is our current definition of MRSS. Mobile Response and Stabilization Service is a home and community-based stabilization service that's designed to de-escalate crises for youth under the age of 21. It's experiencing emotional symptoms, behaviors, or traumatic circumstances that have compromised their ability to function within their family, living situation, school, or community. Next slide. I can see that through the chat, by the way, that Wilma is talking to everybody while I'm doing my presentation. So Wilma, I really appreciate it if you would just pay attention. Thank you. Just kidding. All right, overarching goals of MRSS. What is this service designed to do? And by the way, I am remiss if I don't mention Wilma in a very appreciative way. She has really taken a leadership role in the development of the direction of and the implementation of MRSS in Ohio. And I don't believe we would be as far as we are without her leadership. So the goals of MRSS: establish individual and family safety, obviously, maintain youth in the least restrictive setting, divert children in hospital emergency rooms from emergency rooms and inpatient hospitalization. Certainly an issue right now. Hospitals are quite limited in what they can do, specifically with the Delta virus increasing COVID hospitalizations. Decrease the number of unnecessary arrests in school or in the community, critical factor. And assist youth and families in learning new skills and building supports to reduce the frequency and intensity of future crises. Next slide. So these are the core components of the MRSS model. These are quite consistent with other national programs. There are a few variations here. And Ohio has actually spent a lot of time in promoting some additional components like adding peer support, to the model. So these programs are available 24/7, 365 days per year, with the caveat that we understand that implementing these programs is quite a heavy lift for communities. And I believe the rule that's being looked at right now, there will be an allowance for within 1 year of operation, you have some time to build up to that 24/7, 365. There is a uniform triage process that's expected when calls come in. And, you know, as Dr. Manderscheid was saying, I mean, we have another heavy lift, which is 988. And how does 988 fit within this MRSS model and vice versa? So we have a lot of coordination to do. And I know that Wilma and some of our consultants are working, you know, every day on that as we speak. Families define the crisis, another core component of the model. MRSS responds to the time and place of a family choice to help the family with what the family wants help with. Initial mobile response, again, is 24/7 available. And you'll have some time again to build that within your new program. Within 60 minutes of the call is the expectation. And then MRSS staff respond to where the child is experiencing the problem or the concern at that time. 72-hour initial response is another stage of MRSS, which we'll talk a little bit more about that as we go through the PowerPoint. But this includes the crisis assessment, crisis stabilization, and safety planning. So within that first 72 hours, our job as MRSS providers is to fully stabilize, fully assess, and make sure there's an initial safety plan and a mitigation plan as well in terms of working to secure the environment so to increase safety. The third stage of MRSS is this 4 to 6 week stabilization period. And this is that thing that's quite different than other crisis models up till now. And this is where providers would continue to work with the family if the family so chooses. And parent and young adult peer support would be offered, individual services and supports and planning to meet the unique needs and preferences of each youth and family would be offered. This is what we talk about in terms of, a chance to build emotional regulation skills or behavioral regulation skills. There could be some family-related skill sets that need to be developed as well. So it gives us a chance just to, briefly get in and do some of that work so that the next crisis it does not have the level of impact that this initial one did. And then transitioning. So how well do we link this youth and family via warm handoff to ongoing services and supports? One of the, the answers to this question is going to be with the new OhioMHAS implementation. Every family will be offered either intensive care coordination or moderate care coordination, or possibly limited care coordination. But any child getting MRSS, if they qualify for Medicaid or qualify for a 1915C, would get one of the OhioMHAS sets of care coordination services. Next slide. MRSS staff composition. You'll need an independently licensed supervisor, a licensed or licensed eligible clinician who can either independently diagnose or who can diagnose behavioral health disorders under supervision, and either a qualified behavioral health specialist or a parent or young adult peer recovery supporter. Next slide. And obviously you're going to need coverage and capacity. So that's the minimum that you start with. And then you're going to need to figure out what's it going to take for us to build enough capacity in our community to meet the need in a 24-hour cycle. And again, that 24-hour cycle needs to be available within 1 year of operational status. MRSS clinicians will have immediate access to consultation with the supervisor, as well as regularly scheduled individual supervision and weekly MRSS team meetings. What we've learned from our folks in New Jersey and Connecticut and Milwaukee is that, these teams seem to work best when there's a daily meeting of some sort to talk about where our response teams are in meeting the needs of each youth and family that are currently open to receiving MRSS. So those daily meetings are pretty critical. And so we would encourage each of the programs to develop some sort of way of monitoring and having real-time consultation and planning on a daily basis for each of the families being served. In addition, the MRSS team needs to have ready access to psychiatrists or certified nurse practitioner or clinical nurse specialist for consultation. And much of this language is taken from the currently proposed MRSS rule that's available on the OhioMHAS website. Next slide. So let's dive into the stages. And we divided this into 3 basic stages. And in the MRSS rule, they'll talk about 3 activities: screening and triage, mobile response, and stabilization. Next slide. All right, so that first stage is, that first call that comes in. Because we will have 988, we aren't fully anticipating that there will be either a statewide or a community call line that these calls come into, where they would be screened, but also immediately handed off to the local MRSS team. There are some exceptions, but they're rare. If the call is only information, linkage, or referral, so for example, hey, I need to cancel my appointment for tomorrow. Do you have the phone number of the local agency? Or, that would be wouldn't be a mobile response. Also, if it's a 911 emergency that's deemed an imminent danger to self or others, whether it's suicidal ideation or homicidal ideation with intent, that would be an immediate response from our local folks that do immediate response on that. So, my caveat with this is, let's say that the law enforcement goes out, or the local fire department goes out, or et cetera, and responds. If that child is hospitalized, it's our responsibility as MRSS team to meet the emergency responders wherever that child ends up, right? So if they do end up at the hospital, it would be our job to do our first response really at the hospital. We would let the hospital obviously do their thing, but we want to make sure there's a linkage that's immediate with the family. Then we have 2 other areas: immediate response, which is really any family-defined crisis where imminent danger to self or others is not present. There's an expectation that the mobile response would occur within 1 hour. And again, that linkage would be made immediately to MRSS. And then non-immediate, this would be a family-driven response. So per family or referrer request, it could be a school, a scheduled response is requested instead of an immediate response. There would be phone stabilization that would occur and based on the family need. And then that expectation is still within the next 8 to 24 hours, there would be a response to the family's home or to the school. Next slide. So the critical part of this is that real-time transfer to MRSS, where the crisis line staff, 988, would transfer the call to MRSS immediately. While they're still on the call with the family, they're transferring it to MRSS. And when MRSS is on the call with the family, then they take full responsibility at that point. MRSS staff connect with the youth and family immediately upon receiving the information and given an estimated time of arrival. For those of you guys that are in the field already doing this, you've let me know that it's so important to give the family an idea of, hey, I'm on my way. Here's my expected time of arrival. And, you know, in just saying those two things, you automatically start to begin to build a relationship, but also possibly begin some of your de-escalation en route. MRSS staff offer telephonic support while they're en route. And by the way, en route is spelled with an E-N. I learned that while developing this PowerPoint. I did not know that. So, you know, you're always learning something. Next slide. Triage decision point. So when do you ask for law enforcement assistance? So, you know, the first thing that I need to mention is that we designed the mobile response, initial mobile response, to be a two-person team going out when your capacity allows that, which we believe helps to increase some of the safety concerns. And it helps the ability for you to intervene when you get on site as well. You know, relatedly, and I believe that Marissa Wiesel and Kelly Smith will talk about this, but Medicaid has done a really nice job in figuring out how they're going to pay for this, you know, teamed response, that initial crisis response, differently than we've done that in the past. And so we're supporting the teamed response through Medicaid payment. And that's pretty critical. And that's kind of, for me, groundbreaking. I've not heard of that before. So when do we call law enforcement assistance? So if the situation is deemed unsafe for the worker to respond alone, whether it's violence, possession of a weapon, law enforcement, preferably CIT officers, are asked to respond with the MRSS team to ensure that the home is safe prior to the team entering the home. We want to make sure that the family knows that you'll be bringing law enforcement to ensure everyone's safety. We want this service to look and feel different instead of just a police response, okay? We want this to feel like a behavioral health response with some police assistance around safety if needed. It's important that law enforcement knows that the MRSS role, what it is, what you're hoping they can assist you with during the call, and you take a lead role in setting the stage for the MRSS response, coaching the family, but also really kind of consulting with the police or the law enforcement while you're there, so that they know that you're in charge, you know what you're doing, what you're going to do in terms of helping out in that situation. Next slide. Okay, we're on stage 2, mobile response. Next slide. So in that initial 72 hours, let's talk about what goes on. So you've engaged with the family, you've done your initial outreach. You're going to provide immediate crisis intervention, stabilization, de-escalation of the hot situation that you've been brought into. You're going to develop or update an individualized crisis safety plan in partnership with the family. So before you leave that first session, there minimally has to be some, you know, a small but significant safety plan developed with the family, including, you know, means reduction or mitigation plan, just to make sure that that you and the family feel like it's safe enough until you get back the next day. You want to do implementation of safety precautions in partnership with the family. You begin your MRSS assessment where you'll be identifying crisis escalation and distress patterns. And again, you've got that 72-hour period to do this work. You want to develop your initial MRSS plan in partnership with the youth and family that kind of guides your work. And when OhioRISE begins, we'll be asking you to administer the Ohio Brief Child and Adolescent Needs and Strengths tool, the CANS, okay? I know you guys will have a lot of questions about that, so we'll be ready to answer those as well. So you can see that 72 hours is very intensive. So there's crisis stabilization, there's some initial assessment, there's initial safety planning going on. There's an initial, treatment planning process that goes on to tell you, it says to Medicaid what you're going to be doing and how you'll be paid. You'll also do your CANs that hopefully, if the child is not already in an OhioRISE-like, program, this would create eligibility for them. So these are all critical components, but it is a jam-packed 72 hours. Next slide. So in terms of, I'll break it down just a little bit more. In terms of on-site triage, you'll be doing an environmental scan for the immediate safety, whether it's animals, weapons, people in the home, and immediate risk of harm to self or others. So even though there was an initial triage done by phone, you're going to be doing that kind of secondary follow-up on-site triage because you don't know what you're going to find when you get there. And so you need to be ready to do that in-home assessment. If clinically indicated, you would need to complete a lethality assessment for immediate signs of risk for suicide. One of your decision points during your initial triage is again, hospitalization needed, not needed, based on the results of that lethality assessment. Determine if the youth can be stabilized in the home or if the youth needs a more secure setting, such as a crisis bed or a hospital setting. Our job is to see if we can stabilize youth in the home if possible. But it doesn't mean that we're going to totally avoid hospitals if in fact, or hospitalization or crisis beds, if the youth is just not safe. We'll do what we need to do. Next slide, please. Initial safety planning. So that initial safety plan must be completed prior to leaving the first visit. Obviously, it's done in partnership with the young person and the family. You want to secure unsafe items before you leave. If the child is threatened to take pills, where are those pills? What's the family's ability to secure the environment? Can you walk the caretakers through the home just to kind of make sure those things are secure before you leave? You want to gain a commitment to safety. And you want to develop that kind of 24-hour response plan if another crisis does occur. So between now and the time I come back out again, what will our family be doing? Here's my availability. Do we think you can make it through this next 2 hours, this next 6 hour? You want to keep it very circumscribed and talk about, a finite period of time. Can you make it through this period safely? Next slide. Okay. All righty. And by the way, I want to thank all of the supervisors in the field that have piloted our MRSS programs. I know that, Tori Taylor has been very instrumental in helping develop some training materials on this, and I'm stealing shamelessly from her and her ideas on some of these initial things that we're talking about this morning. Assessment. So you want to assess the crisis escalation and distress patterns for the youth during that initial 72 hours. It's not going to necessarily be the most complete assessment, but you're doing that initial assessment. So what are the warning signs, the triggers, who's involved when that crisis occurs, who contributes and escalates, who walks away, who supports the youth in de-escalation. So what are those systemic dynamics? Crises for youth usually appear in some sort of context, and there's some sort of distress that usually happens ahead of time, right? And it's usually related to family conflict or conflict at school. These are some very common things that we run into. So knowing the dance partners for me is essential. Okay. Next slide, please. So the MRSS plan, as it's called in the rule, you're going to be developing that focuses on time-limited achievable skills, supports, and ongoing stabilization and risk reduction, keeping in mind this is a very brief period of time that you have to intervene with the family. This is not an ongoing service. It's not intended to be that. In fact, there aren't defined caseloads because you just don't know how many crises would be occurring at any point in time. So when you develop your MRSS plan, it's really important to keep your goals, very time limited, very achievable, and that are really targeted to the crisis dynamics that you ran into. Next slide. I mentioned the Ohio CANs. With our rollout of OhioMHAS, many of you have seen the local CANs trainings that are available through the Parade Foundation, the developers of the CANs. And the Ohio brief CANs, according to the rules, shall be done within that first 72 hours by a trained CANs assessor. So you'll need to have your team trained on the CANs. If you are currently certified in the CANs, you would just need to take a booster training, and then during your next certification period, whenever that is, when your year is up, you would then get recertified for the new CANs. If you're not currently certified, you will need to sit through 2 half days of CANs training, one on TCOM and one on actually the tool itself. And then you would then go online to the CANs site at the Parade Foundation to take the test and get certified. That certification during this first year is free. So basically the Department of Medicaid has paid for that certification. And so it's free. All you have to do is, participate in the trainings and go online and take the certification test itself with a score of 70% or higher. So what's the difference between the brief CANs and the comprehensive CANs? Well, the brief CANs basically it's basically used for the initial assessment. It includes core items that are the minimum necessary to determine eligibility for OhioMHAS. So to give you an idea, everything that's in the brief CANs is within the comprehensive CANs. The comprehensive CANs goes into more detail and allows you to access more domains for a more detailed assessment in a certain area, whether it's, violence, trauma, developmental disability, etc. So these are the 2 CANs. For MRSS, you'll be asked to do the brief CANs. Once that child gets transferred to probably one of the care coordinators through OhioMHAS, then they would do a comprehensive CANs. All righty. And I believe Wilma was sending me a coaching letter. If the CANs was done 60 days or less prior to, does a new CANs need to be completed? So, let me just say, for the persons that are putting on the conference, You know, don't ask me a question that I can answer spontaneously during the presentation. But we'll get that answer. And when I quit talking, we'll let Heather jump in and give us that answer. Next slide. These are the domains on the Ohio Brief CANS. Strengths, life functioning, behavioral, emotional needs, risk behaviors, early childhood cultural factors, trauma, and then caregiver resources and needs. There's about, I want to say 56, 58 items on the Ohio Brief CANS. Next slide. Stabilization stage. Next slide. All right. During the stabilization phase, that 4 to 6 week period that follows that, 72 hours of intensive stabilization, the goal is to strengthen the youth and family's capacity to prevent future crises. So there'll be ongoing stabilization. You'll be continuing to monitor the situation, continue to do risk reduction, continue to update the safety plan. So within that 4 to 6 weeks, you're going to learn a little bit more about this, the crisis escalation pattern of that youth and that family, and what's helpful and what's not helpful. You want to keep updating that safety plan. The goal here would be, when you are done with your service, whoever takes on this youth and family, is helping this youth and family next, has a fairly comprehensive safety plan based on some really solid information. This is also the period that you have to do, again, brief skill building. It could be around emotional regulation, coping, distress tolerance skills, problem solving, etc. So what are those core skills that this youth or family needs to reduce the acuity of the next crisis or the frequency of those crises in the future? Again, as we said earlier, you want to not only address what the youth is going through, but what that youth in context is going through, whether it's with family escalation patterns, or are there certain accommodations that youth needs at school to do better in school. And of course, we're going to look to begin to identify what are the resources and supports that youth and family need to be successful on an ongoing basis. We'll also look at some behavior management strategies that we can work with the caretakers. And of course, during that 4 to 6 weeks, we're going to be looking at coordination and linkage to ongoing service and supports. So once we have the Ohio RISE program up and running, there should be a seamless transfer linkage to care coordination. That care coordination should already be involved by the time, that 4 to 6 weeks is up. So, this will be a lift. We're going to have to work through some of these things. But the ideal situation is MRSS gets involved. If care coordination isn't already involved, they would get involved within that 4 to 6 week time frame and begin to plan for that initial, or even do the initial child and family team meeting. Next slide. So skill building tasks, I just listed a bunch here that are typical ones that we've seen in this first 4 years of implementation here in Ohio. So lots of de-escalation skills and strategies, lots of work on emotional regulation, coping, and distress tolerance, problem solving skills and strategies. It could be communication, skills related to communication. It could be helping caretakers understand the cues. What are the warning signs for this particular youth? And then what are some prevention skills and strategies that you could implement with a focus on not only skills, but what accommodations need to be in place, what supports need to be in place for that youth to be successful. Next slide, please. And when we talk about support building interventions, we're also talking about what's that initial identification and expansion of natural supports. So is it extended family that supports the parents? Is it, the neighbors that support the kid, or, the community? Are there mentors involved that are working with the youth? So what are the natural supports that are available to help out? We believe that youth and family peer support is an integral part of helping families, bringing the lived experience support, if you will, to the family. We have seen this work extremely well with our programs that have implemented, family peer support in particular. Collaboration, coordination, and linkage with key stakeholders is going to be important. And some sort of short-term care coordination and linkage, utilizing child and family team meetings, as I just mentioned previously. Next slide. In terms of, expanding the natural supports, there's a couple of tools that you can utilize to do that. I mean, you can use an eco map, you can use a genogram, you can use a social support map. The genogram is really interesting. It's basically a family tree, an extended family tree, 3 generations of the family. Who's available to that family? Are there folks that were available in the past that might be available now? Maybe there were some bridges that were burned, but maybe we could help mend some of those fences and bring that person back in to help with a very targeted kind of a support. All right. One of the things that I've learned doing services over the years is that we tend to burn out our support systems when we ask them to do too much over too long. Okay. So in that, those services are more targeted. Will be much more helpful. All righty. Next slide. Parent and youth support. So parent and youth support is this lived experience support that provides system navigation, advocacy. It helps to level the playing field. Offer shared experience, shared understanding what that family is going through. When we did our resiliency leadership group years ago, we were told from families that we just need to be validated for doing the best we can with what's going on in our lives right now. And too often they weren't validated, and they were judged by the providers coming out to do the helping. So it's a message to the provider world, but it's also what parent and youth peer support do best. They validate the family on doing the best they can in a very difficult situation. They may provide mentorship. They might provide information and guidance, emotional support. Probably most importantly, they may provide hope to the family that things can be better based on their lived experience. And they share stories about how their situation got better. And very importantly, system navigation. So this is the first time that the family is involved working in this very complicated system that we have of helping. How does the family navigate that? So if this child has a problem at school and they're on an IEP, or they have juvenile justice involvement, or there's child welfare involvement, and now there's a behavioral health issue, that's a lot of system to navigate. And once we get involved, are there more than one of us coming out to do the helping? Okay, so what's the right amount of help that family needs to get better without being overwhelmed by all the people that are going to work with them? Okay, next slide. Transition for MRSS. So at the end of your 4 to 6 weeks, and it could happen earlier, because not all families request to participate in that 4 to 6 weeks. You want to develop some sort of an ongoing maintenance plan. You want to review and practice whatever the learned skills are. You want to predict possible barriers, bumps in the road, and help them with a plan B if that barrier is encountered. You want to review the safety plan. And you want to have a way of transferring, this kind of real-time transfer of the safety plan, almost like a baton in a relay race to the next set, to the next providers. And you want to facilitate that connection actively. Next slide. I think one of the most important things that I want to emphasize today is that with this MRSS program, it is still a very short-term focused intervention. It's not meant to be long-term. It's not to replace any of the current services that we have, but it's meant to be a lifeline. It's meant to go in and do a little bit more stabilization than we've done in the past through our crisis services. If the service goes over 6 weeks, my understanding is there would have to be some sort of an authorization for ongoing work. The question would be, are there other services that at that point can take over, whether that's intensive care coordination, intensive home-based treatment, et cetera. Okay, so this is short-term. You want to help the family understand this is a very brief time we're together. The trick is engaging quickly, but not so much that the family has trouble letting go of you as that brief, time-limited provider in their lives. Next slide. All righty, so I've reached the end of my slides. I want to point out a couple of other things before I take questions, or we'll try to answer many of Wilma's questions. First of all, you should have gotten the slides. I sent them to you. If you didn't get them, put them in the chat. I also, at the very beginning of today, put the fall training schedule in the chat box, okay? So you can download that, and on that are actually registration links, and our friend Matt Weiland will load those onto our Wraparound Ohio website onto the MRSS page, so that'll be available through there as well. All righty, I will now take questions.
Thanks, Rick. I can't see if there are any in the chat yet.
Yeah, there is. There is, Laura. There's one. Has it been determined how agencies will be reimbursed for providing this service?
Well, Pam, I'm so glad you asked that question. I want to thank Wilma and Laura for being so planful in this conference, because coming up, I think in your next workshop, you'll be hearing from Marissa Weisel and Kelly Smith, and they're going to talk about very specifically about how the service will be reimbursed through the OhioMHAS program. So I will not steal their thunder.
Yep, that's coming up at 11:15 after our brief break.
What I will say, Pam, is that the structure of funding for OhioMHAS is for Medicaid kids and or kids who are on the 1915C waiver. We'll still have to figure out as a community how other kids get those services, get these services in particular. And so it's going to really be important, if you're implementing an MRSS program, to have a community network approach to building that service and talking about how will we sustain the service over time. Don Carter asks, what percentage of costs associated with MRSS have been covered by Medicaid with current programs or expected to be reimbursed?
I can answer that, Rick.
Thank you.
Okay. With our data that we have been collecting, Don, The first thing is that people for the first 2.5 to 3 years never even billed Medicaid because they had grant dollars. And so we got people to start billing, but and right now, about 30% from one agency, a lot of agencies just haven't done it. But understand that under Medicaid, the new way, and again, Marissa will get into this, the way that you bill Medicaid for your services now will be different when they start billing for MRSS. So you can't make, it's like apple and oranges. So you can't make that equation to be the same.
Thank you, Wilma.
Mm-hmm.
Erica asks, will there be formal documentation forms for all of these required pieces? You know, that's a great question. I think that's more of an Aetna question if we're going through OhioMHAS. I don't believe we have required a standardized, for example, safety plan. I think we have recommendations about what components should go in a safety plan. We recognize that all of you have your electronic health records that have loaded up a safety plan that you've chosen previously. But there could be some adaptations to that are required moving forward. And that we'll get that information to you as we know it. And I'm looking through some of these others. If there is a concern about the safety of the MRSS staff, how is this usually handled? Do the police accompany the staff? You know, I think these decisions are made on a call-by-call basis. But certainly if there is a safety issue that's identified, that could be potentially a safety issue for the staff themselves, whether it's, you know, a family violence or there's a weapon involved, you would want to have law enforcement accompany you to that call. And we'll get into those specifics a little bit more in the actual 2-day training that we do around that. We want your staff to feel and be safe. But that's not all situations. And again, one of the things we're trying to do is to change the culture of the response to make, you know, in that we can make this a behavioral health response instead of a police response. So those decisions are made call by call, and those, you know, we are certainly anticipating that there will be times where you'll need to partner with local law enforcement, which means you might want to have an MOU or some sort of ongoing communication relationship with your local law enforcement to talk about your new MRSS service, what it is that you need from them, what it is they need from you. All right. So those conversations are ongoing. And I think safety begins with those initial conversations with local law enforcement. Any other new questions here? Jeff writes, early adopters for the MUT program in Milwaukee, the CCOR, I don't know what that stands for, Jeff, program in King County, Seattle, New Jersey and Connecticut, and a few other states like Nevada, Oklahoma, adapted existing models to these best practice approaches. So many of these, if I'm not mistaken, and Jeff can correct me, many of these programs started as mobile crisis programs that over time developed more fully into this new version of, you know, more of an evolution into mobile response stabilization programs that we're seeing. So you get a tremendous amount of experience from those initial programs, and we have some of those in Ohio. And again, this is just an evolution or a next step in the development of our response to families. Okay, any other questions?
Someone asked a question, Rick, about what is the MRSS response for youth in detention home facilities? Would this be considered non-immediate and scheduled unless the youth was in immediate risk? Who's calling? I mean, Amanda, you asked the question, who's putting in the call for the MRSS youth? If the youth is in a detention facility, are you saying that the parent is calling, saying something is happening to their child? I'm not clear about what you're asking here. Amanda, could you speak up? Come off of mute.
Yeah, sorry, I just sent it in the chat. The actual detention home staff, not the parent or the guardian.
So the detention home staff call and says what?
Like they have concerns about the youth and they're wondering if someone can come out and assess. Just like how a school staff would call.
Okay. And so you're asking, would this be an immediate versus?
Right, just the MRSS response, could that be something that's scheduled too, like if there weren't an imminent risk?
And if that's the case, it could be that it still have to be within that 60-minute window, okay? Sometimes there's a lot of intricate other details that you have to get. That's why I couldn't answer that. We couldn't answer that question. And that's the same way you have to ask the questions when the people are calling you, okay?
Amanda, I have a question back at you. Do you do current crisis response to detention centers?
We do, yes.
And do you get paid for it?
Yes, it's part of our, yeah.
Yeah. So, I mean, part of the issue here is what Medicaid will reimburse in a detention center versus in a different setting, right? And maybe we can ask, Marissa to expound on that. But when youth are detained, and detention is that weird, in between place. But if they were in DYS, for example, they would not be able to, if you provided a service there, be reimbursed by Medicaid because DYS is supposed to provide all of those services for that youth. So this is partially also how will you be reimbursed question.
Okay.
Yeah.
Yeah. Or is the reimbursement, Amanda, is it a situation where your county juvenile justice system and your mental behavioral health system have a contract with each other?
Yeah, so our board, our mental health board has a contract for us to provide services in the detention home.
And do they have a contract with the juvenile justice where they're paying some money for that to be taken care of? See, that's why it's not as simple sometimes.
Okay,
one thinks.
Yeah, I was just wondering if there were like certain criteria or like a certain,
Yeah,
rules around that.
it's the same rule overall that they call, you get there within 60 minutes.
Okay.
Okay.
So the only other option would be, Amanda, if in fact the detention center says, but now is not a good time, can you come at, and so if the caretaker at that point is requesting a different time frame, that would be acceptable within that 8 to 24 hours period.
Okay. Thank you.
Okay, I think we're almost up against it. Any other last questions here?
I think we're just about out of time. If someone could Rick or Matt put the link for the CEs for this session.
I will go ahead and do that.
Thank you.
And there's one, I'll do one. Sarah Becker says, Tawny has a question. What happens when there are long wait lists or no availability of needed service in the local community? How does discharge happen? I mean, it's a great question. And I think what we've experienced is that when services aren't available, we tend to hold on to, the youth and families we're serving longer. And, we have to, again, this is why these are community issues. We have to figure out what is our system of care for kids. If we're going to honor the fact that if you really want a functional MRSS system, you can't hold on for more than that 4 to 6 weeks. It just won't work. And so it's a give and a take. So it's expanding that. Our hope is that with OhioRise, that there will be increased access to other services on an ongoing basis that can take over when MRSS needs to transition on. All righty, I'm going to put the link for the CEUs in the chat. And I believe we're up to our first 15-minute break.